Thanks, Mike. Good afternoon, everyone. Around the world, we are now at a total of over 31 million cases and 960,000 total deaths from COVID-19. The United States, as of this morning, is over 6.8 million cases and 199,000 deaths. Here in Minnesota, we've reached a new total of 90,942 cases in Minnesota. There were 937 positive cases on yesterday's test volume of just under 17,000. Saturday's new case total of 1,318 cases that was reported yesterday was obviously a new one-day record by a significant margin. We are now at a total of 1,969 deaths from COVID-19 in Minnesota, which is up 4 from the day prior. 2 of these deaths occurred among residents of long-term care facilities. 1 each of the 4 deaths were in Beltrami, Douglas, Mower, and Renville counties. This total includes 1 person in their 90s, 2 in their 70s, and 1 in their 60s. The hospitalization picture remains fairly stable, with 255 patients currently in the hospital, 128 of them in intensive care. As I mentioned, we had a very strong testing volume for the last several days, and that brings our weekly change in testing to 7.8%, comparing today with the week prior to today. So that 7.8% is up from 6.1% growth in testing volume the week prior. Comparatively, the weekly increase in cases is 7.1%, up from 4.6% the week prior. So you can see that case growth jumped more quickly than testing growth on a percentage basis. The 7-day average testing positivity rate as of September 12th, which is before the lag period, is 4.4%, down from the prior week's rolling average of 4.8%. However, it's important to note that several regions of the state do remain over the 5% test positivity level. As a state, we have seen the positivity rate decline for 10 days now. With that, I will turn it over to Chris Erzman.
Thank you, Commissioner. I want to comment on the high case numbers that we are seeing. We've seen a high count of new cases in recent days, including the record high of 1,318 cases reported on Sunday. And I do want to note that that number was a new case record and does not reflect any backlog or other events. And while it is a record, it's not a record that we're pleased about. We knew as we headed into the fall that there would be a number of factors that might put upward pressure on our case numbers. This includes K-12 schools and higher education transitioning back into fall classes, as well as other activities and events. One unfortunate issue our epidemiologists have encountered at times is an apparent reluctance by people, COVID-positive adults or parents of COVID-positive children, to share key information with public health case investigation callers. This may be due to people seeking to avoid the limitations that go with isolating COVID-positive people or those who have had a high-risk exposure. While this may be tempting in the short term, it actually makes it harder for all Minnesotans because it boosts the risk of COVID spreading to others in your school, your athletic team, your church, your workplace, and some of those people may be at high risk for complications. And so ultimately, we will find the cases, even if via a circuitous route. No one wants to have to deal with the disruptions of COVID precautions, but trying to duck individual responsibility makes the problem worse overall and could lead to a friend or even a family member having a serious health problem. With this in mind, we urge everyone to listen to their healthcare providers and public health officials when they are asked to take an action to limit potential spread. We know that most Minnesotans are working hard and doing their part, but if a significant number of people don't do this, the result can be prolonged problems in their community and school and social circles. And with that, I'll turn it over to Assistant Commissioner Dan Huff.
Thank you, Chris. Good afternoon, everyone. I am pleased to announce that on Wednesday, September 23rd, we will open the first semi-permanent site for COVID PCR saliva testing in Minnesota at the Duluth Entertainment Convention Center, or the DEC, in Duluth. The Duluth saliva testing site is the first of its kind in Minnesota, expanding and diversifying the COVID testing options available to all Minnesotans. The testing site at the DEC is the first of what will be 10 semi-permanent sites across the state. They are open to all Minnesotans who believe that they need a COVID test. Testing is free, and you will not be required to have an ID or insurance. It is open to anyone who feels they need to be tested, whether or not you have symptoms, but especially if you were exposed to someone who tested positive for COVID. Tests taken here at the DEC will be shipped to Vault's New Jersey lab until the Minnesota Saliva Lab that we announced a couple of weeks ago is operational in mid-October. Results will typically be available within 24 to 48 hours of reaching the lab. The Duluth site will operate Wednesday to Friday from noon until 7 p.m. and Saturday and Sunday from 10 a.m. to 4 p.m. And while it is open to walk-ins, we do encourage you to register in advance. It makes your appointment go faster, and it allows us to avoid crowding and long lines. The state is partnering with Vault Health as part of an innovative partnership meant to increasing access to testing options for Minnesotans. Vault Health will operate the Duluth site. The team is experienced. They have run sites like this across the country. Minnesota has come a long way in our testing capacity, thanks to the existing partnership with Mayo Clinic and the University of Minnesota and the state's various health systems. But we know it's critical to grow and diversify our testing capacity, thus this new testing opportunity. These semi-permanent sites are not meant to replace the COVID testing options already available to Minnesotans. This is an additional option to make COVID testing even more readily available to all. This innovative partnership will also include the creation of a saliva testing lab right here in Minnesota. This lab, which is going to be located in Oakdale, is in development right now. And once opened in mid-October, saliva tests will be processed in Minnesota, limiting a potential delay from travel, severe weather, or other things that might disrupt shipping. Hiring and training at this lab is underway, and it will ultimately create up to 250 new jobs. This new lab will be capable of processing as many as 30,000 samples a day, greatly increasing our testing capacity here in the state. The opening of the Duluth saliva testing site at the DEC marks the first time that saliva testing will be available to the general public in Minnesota. Growing and diversifying our testing volume is a big part of our entire state's COVID strategy. Saliva tests, you may recall, were recently made available to all staff who are employed in Minnesota's child care centers, as well as schools pre-K through grade 12. As you know, testing must be combined with masking, social distancing, and then isolation or quarantine when appropriate. testing is one part of this entire package to slow the spread in Minnesota. Increased access to testing and identifying positive tests as early as possible is critical to keeping our schools and our economy as open as possible. Helping someone find out that they are positive early helps them protect others. But positive cases staying hidden will only cause more spread and more detrimental impact to our schools and to our economy. Saliva testing method reduces the need for extra supplies, such as PPE, because we don't have to have a clinician do a nasal swab. That saves in masks and other types of PPE and allows Minnesota to be more resilient by diversifying our testing strategy. I do want to thank the DEC in Duluth for partnering with us, and the DEC will be still operating other events and activities because they're a large venue. They're able to do multiple things safely. So we do appreciate the partnership with the DEC. Thank you. I will now turn it back to Mike.
Thanks, Dan. Operator, we are ready to take questions. Operator, we are ready to take questions.
At this time, if anyone would like to ask a question, please press star 1. To withdraw your question, please press the pound key. First question, we have Jeremy Olson from Star Tribune. Your line is open.
Hi, thank you. I wanted to ask about today's, over the weekend's guidance from the CDC or acknowledgement of the risk of aerosolized transmission of COVID-19, that perhaps particles can spread farther than 6 feet and infect others, and then the subsequent retraction of that information from the CDC website. My questions are, one, are you considering aerosol transmission a risk as you do your planning for schools, just in general? And also, is it frustrating to have to deal with kind of yo-yo information coming from the federal agency?
This is Jan. I'll start, and then we'll ask Chris to chime in if she would like. I think in general, certainly we have and will continue to look to the CDC for guidance, as we always have. But we do and have in the past continued to kind of look at the science ourselves and make decisions to, in some cases, stick with our guidance even when the CDC guidance might be changing. That was true about testing of asymptomatic people, for example. And we will continue to follow the science around aerosolization quite closely. And in terms of how that plays into our current guidance, I would ask Chris if she'd like to comment.
Oh, thanks, Commissioner. Yes, I mean, I think that we're trying to balance the data that's out there related to transmission, and so our guidance to the public has focused on, 6 feet of distance, masking, and those types of things. Certainly, we know that aerosolization can play a role in transmission, and so we've been attentive to that, and so we'll continue to do that. The challenge with COVID is that the data, we're continually learning new things, and so because it's a new disease, we do have to continuously adapt our recommendations as new data come out. And I think that for the public, that's really challenging and very frustrating. But to keep in mind that this is not, say, an influenza pandemic where we have, centuries of experience with influenza, and now we're dealing with something new, or some of the other diseases that we've talked about where we do know a fair amount about the disease. We're just dealing with it in a new way. With COVID, we are absolutely learning new things all the time, so we continue to adapt our guidance. And so we'll continue to look at the role that aerosolization can play in transmission as we go forward.
Another question is with respect to your testing, the Saliva Testing facility, your no barrier testing last week, a lot of the free clinics and things that are being offered in counties with hotspots. Collectively, it seemed like all of these will result in an elevation in cases spotted every day and an increase in our case rate. And as the Assistant Commissioner said, that's a good thing. You want to know where cases are. But a lot of we're kind of judging a lot of things on our case numbers and case rates. Our dashboard has that. We're basing school decisions in part on that. And suddenly we're going to be inflating our case numbers. I guess I'm concerned. My question is, are you concerned that we're going to be inflating these numbers in an artificial way almost that's going to result in us forcing to make policy decisions because of that growth?
Jeremy, that's a great perceptive question. This is Jan. That's really why we have said all along we need to look at multiple factors and how they play together. So no one number, whether it's case growth or hospitalizations, is the sole or most important measure. We do look at test positivity as a very key way of kind of factoring in the increased volume of testing to make sure we're testing enough, and that as the percentage of positives we find as we continue to test more and more goes down, that's a positive sign. The percentage of cases that are coming through community transmission of unknown source is another critical variable we track because that's so very important to our ability to identify hotspots and to intervene quickly. So between those measures of disease prevalence, testing capacity, as well as healthcare capacity, we really do need to come at this from multiple different vantage points, because you're right, if it was just case growth in and of itself, that might lead us in one direction. It's also the reason we say county case numbers are the beginning, not the end of the conversation, and that the epidemiologists and others consulting with the schools take a look at, are there explanations for the case growth? And you just laid out kind of the most obvious one. If we're doing a lot more testing and that is resulting in the identification of more tests, cases, that is not in and of itself indicative of an out of control situation. I hope that's helpful.
Well, and
yes, thank you.
This is Chris. If I could just add something, Jeremy, you used the term artificially inflate, and I think we want to be clear that when cases are identified through testing, that is not artificially anything. That is identifying what's out there, and the sooner that we can identify cases, the sooner we can take action. So and the commissioner answered the nuances of how we look at the data as it relates to schools and different things, but I do want to be clear that testing is simply finding cases that are there and have the potential to spread to other people. And the good thing about it is that it allows us then to take action. If we don't know about a case, we cannot respond or take action.
Thank you.
Next question, we have Kate Raditz from WCCO-TV. Your line is open.
Thank you, Commissioner. I'm curious, can you talk about how many schools you know of in Minnesota that have had confirmed cases so far with students going back, a lot of them going back? And I know at one point there was, I think, possibly talk of a website to have that information in a central place. I didn't know if that was still something in the works.
Yeah, I'm going to ask Chris to respond to whether she's got current cumulative data on number of schools. We have noted that the number of new cases each day coming from schools is now exceeding about 60 new cases each day out of the school community, which doesn't necessarily mean, and often doesn't mean, transmission at the schools, of course, which is a nuance Chris has talked about before. But Chris, can you update on any more school numbers?
Yep, we're aware of 351 schools that have been impacted by COVID. And what I mean by that is they have had at least one case. So 263 have had at least one case. 81 have had between 2 and 4 cases, and 7 have had 5 cases. And we're continuing to work on putting together the dashboard to be reporting on what's happening in schools. So that the team is continuing to work on that. And we've had some challenges because so many folks are working remotely. We've had a couple challenges in accessing data. So we were a little slow with the numbers today. That's why the commissioner had to rely on me because we didn't get them to her as quickly as we could have. But we are working on that, and we will have something on our website.
Great, thank you. And just a follow-up, you know, I did look at the COVID response. I think it's called the tree of what schools do if they have a case or a possible case. Are they required, though, to send out that information to families in a school, or are they just required to report to the families that are affected? Is there any kind of guideline there as to who they have to tell that, hey, we've got a COVID case, or is it just kind of a case by case?
Our recommendations to the schools are layered, if you will. So in other words, obviously, as with all of our case investigations, we identify who the case is and who their close contacts or close exposures would have been, and that's true for situations in a school setting as well. And so the notification that goes to those individuals is fairly specific and detailed. And so that could be a classroom, depending on the age of the students and their interactions. That might be a classroom setting, let's say in an elementary school. But then our recommendation is that they would send something to the broader school community, just alerting them that there is a case in the school, not that there's anything that anyone would need to do, but just for transparency. So that's kind of the two layers of guidance that we provide.
Got it. Thank you.
Next question, we have Matt Savick from Minnesota Public Radio News. Line is open.
And to follow up on the school question, I know several in southern Minnesota have started dialing back on in-person learning. Did the state, did the health department have a role in those decisions, and do you expect more of those decisions?
Chris, could you comment?
Sure. Matt, as you may or may not know, the department, in collaboration with the Department of Education, have stood up regional teams that are working with schools and school districts within multiple regions across the state. And so when there is a situation pertaining to a case in a school or within a school district, those teams are working with the school and with the district. And oftentimes, I mean, we're there to provide assistance and guidance. Oftentimes what happens is it's not so much that it's the Department of Health or the Department of Education saying this is what you have to do, but oftentimes the district will say, you know, looking at this situation, because of these exposures, we have a certain threshold of staff that are not going to be able to come in, or we're looking at our senior class, and this proportion of our senior class has now been exposed, and so, you know, they're all going to have to quarantine. It makes sense to consider distance learning in that situation. So it's definitely, you know, a discussion and a collaboration.
Okay, thanks. And also, I wanted to hear your reaction to the decision by the State High School League to resume football and volleyball games, and what effect that may have on COVID case numbers.
Well, this is Jan. I think as we talked about some last week on these calls, we certainly, as parents and community members, are very well aware of the importance of youth sports to those student athletes and to the broader community. And certainly Governor Walz has a deep personal connection to high school sports as well. And we know just that this is just yet another of the activities we most love that has been put in question by COVID. We respect the fact that the high school league, that this is their decision and that they've taken a thoughtful approach throughout to trying to weigh the risks that are involved with playing football and volleyball this fall. I think they're aware that there is some risk. And I think we all expect that the season, how the season looks, will be influenced by what direction the pandemic takes from here. And we all know, and we believe that the high school league is quite focused as well. And we expect that they will be taking all the safety measures that they can to ensure that the student athletes can compete, but that they can also go to school. Which really means, again, extra vigilance on everybody's part, players, coaches, spectators, fans, to really pay close attention to masking up, whether you're in the stands or on the sidelines, even when we're outdoors, keeping distance and limiting the number of spectators who can attend. So we do believe that those mitigation policies will be important, and that both the health department and the Department of Education and higher education remain available to help our K-12 and higher ed institutions with planning and policies to mitigate these risks. And certainly we look forward to continuing that dialogue with them.
Okay, thank you both.
Next question, we have Paul Scott from Forum News Service. Line is open.
Hi, thank you. I was wondering about your observations about the adherence to crowd limits guidance at the Trump rally in Bemidji on Friday. I think we saw estimates of 2,000 attendees. Did they adhere to the guidance? And if not, do you have any plans to penalize the venue or the organizers?
Well, this is Jan. It does not appear that they were very focused on the guidance, and I can't comment today on any planned follow-up activity. I've not been involved in any of those conversations in the last couple of days, but I will just ask if any of my colleagues maybe have any information I don't have.
Okay, thanks. Here's an unrelated follow-up, if that's okay. We're wondering whether tribal communities are among the groups you consider under-tested at this point for COVID-19, and if so, are you planning to ramp up testing in those communities as part of the no barrier effort?
This is Jan again. We are in very frequent contact with our tribal nations. They are our partners in public health, and to be sure, and it's our job to support them in undertaking the strategies that best fit for their communities. We do certainly inform them of the community testing events. They're certainly more than welcome to participate, and we also have made sure that they can access the resources that are available under the state's testing program to do their own events. Definitely, I think there are additional resources to be coordinated with through the National Indian Health Board and the like. So there's just a couple of extra pieces there related to tribal sovereignty and also other resources that they have directly, but we have very much every interest in making sure that they can also avail themselves of the state's resources. Dan, I don't know if you would have anything else to add specifically on that.
Thank you, Commissioner. Everything the Commissioner said is absolutely accurate. We have been asked to and have partnered with various tribes in setting up these community clinics, both in Boys Fort as well as Prairie Island, and we coordinate regularly with all of our tribal partners to provide them whatever assistance that they request from the state as far as testing resources. Thank you.
Thank you.
Next question, we have Sloan Martin from WCCO Radio. Your line is open.
Hi, I had a question. I know this is something you spoke about very early on about just kind of questioning the market in terms of the sensitivity and reliability of antibody tests. And I was wondering if you've seen any more progress since since then? Should people try and seek them out, even though that immunity only lasts a couple of months? What are you seeing right now in terms of those specific tests?
Well, thanks for that question. You're right. We have flagged that as something to watch to make sure that the tests that folks are getting, that they check that out with their providers or with us to see if the specific test is something that has been given FDA emergency use authorization, or just where it stands. But certainly there's a lot of activity in the field of test development, a lot of progress being made. I would see if Chris would have anything to add specifically on sort of the general state of sensitivity in antibody tests.
Thank you, Commissioner. Yeah, I think the challenge with antibody tests at this point is that while they can be useful from a qualitative standpoint, what I mean by that is kind of a yes, no. Does this person have antibodies or not? So they could provide that information. What we don't know, as you alluded to, and the Commissioner as well, is what we don't know is how much antibody would be necessary to indicate that a person has some level of protection or immunity from COVID. And then the other thing that you acknowledge is the fact that we don't know what the duration of that protection would be. And certainly we've seen there have been instances where individuals have been identified as having a second case of COVID, and whole genome sequencing or molecular testing has allowed scientists to identify that the first case was different because of the genetic sequence from the second case. So we know it's a completely separate case. So we know that can happen. And so that's really the challenge with antibody testing, is certainly it can tell a person if you have antibodies or not, and that may be useful, but we don't know if the level of antibody is sufficient to provide protection, and then we're not sure how long that protection would last. So still a lot of questions that haven't been answered in that area.
Thank you.
Next question, we have Tom Hauser from KSTP-TV. Your line's open.
Hello, Commissioner. You don't sound thrilled by the high school league's decision on football and volleyball. I was curious, if you were making the decision, would you say that football and volleyball should not be competing this fall?
Well, that's a fair question. I think, all along we've sort of acknowledged that balancing these various perspectives and factors is a challenge. That from a pure kind of public health risk protection perspective, you might say, well, we know there's a lot of viral activity in the community. It's at a high enough level that we would prefer not to have events that would just gather more people and create more opportunity for transmission. However, we know outdoor environments are safer, and we certainly know how important these activities are to the student athletes, to their families, and to the community. And we think that it's a risk calculation, and there's certainly trade-offs and risks and benefits. And so even though we might weight the scales a little bit differently in terms of that risk balance, risk-reward trade-off, we certainly recognize there are positives to youth sports as well. So respect the high school league's decision. And again, I think our focus at this point is just on hopefully helping to educate folks about the importance of the risk mitigation strategies to make this as safe as possible.
And just as a quick follow-up, I know there's a lot of unknowns about the future a few months down the road. Would there be much of an appreciable difference based on what you do know now of playing in October as opposed to playing in March, which I think was their original plan, in terms of the risk?
Yeah, it's a great point. I don't think we can forecast, whether the risk will be greater or lesser by next March. We certainly hope it's less for a whole bunch of reasons, but And there's just so much unknown about the further trajectory of the virus, some of the reinfection potentials that Chris just alluded to and the co-occurrence with influenza. So that we can appreciate that March didn't necessarily seem like a safer bet for this decision.
Okay, thank you.
Next question, we have Gordon Severson from Care 11 News. Your line is open.
Hi, I was just wondering if you could comment on the hospitalization and death rates going down. What can we possibly attribute that to?
But this is Jan. I'll start and invite Chris to comment too. We mentioned before, I think, a couple of things. Both the demographics of the cases in this second wave have been different. The ages of the folks with the more recent cases are significantly younger. And while there can be very bad disease and tragic outcomes for younger people as well, statistically, lower percentage of younger people develop severity of disease that requires hospitalization and occasionally does result in death even for younger people. But just the sheer demographics of who's being exposed recently has shifted. Also, treatment approaches really have improved. While it's still the case that there are no flat-out cures, and we still have to keep reinforcing that we just don't know enough yet about long-term health impacts of cases, even after someone has kind of come through the acute phase. Treatment approaches have improved. We know more, clinicians know more about how best to manage COVID, getting the right kind of oxygen therapy. Some of the pharmaceuticals like remdesivir and dexamethasone have proven beneficial in improving outcomes. So it's a combination of all of those factors, and we're really grateful for it. We do note and have noted before, though, that even though the more recent cases are younger, we do worry a lot about sort of the transmission from younger people to people in higher risk groups. And we have seen an uptick in cases among long-term care residents again, this time coming from, it appears quite strongly through our case investigation process that the long-term care cases now are not resident-to-resident transmission in the facilities, but are healthcare workers being exposed in the community and unknowingly bringing the virus into the facility. So there is, and we expect will be, a correlation between the lower risk of younger people in general, but again, not in any way are young people not vulnerable to very severe disease or even death. But we do expect that with this high level of cases, there will continue to be transmission to higher risk groups as well that very likely will drive up hospitalizations further from this point.
And this is Chris, and I'll just add that I think it's important that we, celebrate positive things, as the commissioner said, with the better treatment and a better understanding. But I think it's important that while we're seeing positive trends with hospitalizations and deaths, that we not readjust our thinking to somehow think that COVID isn't serious. Because as the commissioner alluded to, we're just learning about the long-term consequences of COVID that may, in fact, be silent. And by that, I mean that someone may have mild or even asymptomatic disease and yet still have long-term consequences. So, even as we celebrate some positive data, I just want to be cautious that we don't want to suggest or have anyone think that somehow lessens the seriousness of this disease.
Thank you.
Operator, we have time for one more question.
Next question is from Jeremy Olson from Star Tribune. Your line is open.
Hi, my friends at the Pioneer Press late last week had reported on a situation in which one of your surveyors encountered a group of people with weapons, And I just wanted to follow up on that and find out if that, just to get your comment on that, or if there's been any further concern regarding your surveyors out doing the testing work, or if that was just an isolated incident.
Well, this is Jan. Yeah, I'm sorry to say that did happen, and it was very much of concern to us. And while I don't know all of the circumstances, and Assistant Commissioner Huff or Chris might have any additional comments, I'd welcome them to make. But we certainly want to be sure, number one, that we do a good job of letting the community know what we're doing, why we're doing it, why this study is important, and would hope that people would respect that and understand it. We appreciate, frankly, some assistance from the media in kind of helping us get the word out that certainly we don't think in any way, shape, or form that is characteristic of how Minnesotans feel about people doing this important public service. But it's just important to also help people understand why we're out there doing things like the Casper study and the value of it. Jan or Chris, do you have any more comments? Certainly we are trying to step up our procedures to make sure that our staff are appropriately supported and protected. Nothing from Chris.
Commissioner, this is Dan. So the incident did occur, as Commissioner Malcolm said, last week, as one of our survey teams was in the field, and they were confronted by 3 men, one of whom was armed. Our team responded appropriately. They left the situation as soon as they could, and checked back in with their supervisor. We did report the incident to the Department of Public Safety, that has been working with chiefs and sheriffs around the state, making sure that they are aware of our teams in the community. It does signal a concern for us. Public health practitioners are used to working in the community. We do that every day. We believe strongly in our connection with the community, but we are concerned. We understand that this is a time of anxiety, and a time that anxiety can bring fear. But it is really important to remember that everyone who is engaged in this response is doing so that we can protect the health and the lives of as many people in Minnesota as possible. So it is unfortunate. I think it is a signal of the fact that these are anxious times for folks, but I am so thankful for every public health employee in the state, at the local and the state level, and the federal partners who are working with us. This is difficult work, and they are often behind the scenes, but I think of Chris, I think of her team, I think of all the folks, our brothers and sisters at the local level, are doing tremendous work on the benefit of all Minnesotans, and I think it's unfortunate that this incident happened. Thank you.
Dan, thank you for these comments. Very well said.
That's all the time we have for this afternoon's call. If you do have any follow-up questions, feel free to reach out to the MDH Communications office this afternoon. Have a good day, and we will be back with you again on Wednesday.
This has been a WDIO News Special Report.